Betty Jo, the chat's already getting busy. People saying, "Hey, Betty Jo from Mount Carmel."
The old stomping ground. Fantastic.
All right, we'll go ahead and get started now. Thank you everyone for joining. Today we're going to be covering this topic of how Mercy CNO recruits and retains nurses. We're going to be, my name is Iman Abu Zaid. I am an MD by background. I'm the CEO and co-founder of Untitled Health, which is the fastest growing career marketplace for permanent nurses. Hospitals and health systems use our software to hire permanent nurses in 20 days or less. We flip the script. The hospitals and health systems apply to the nurses, not the other way around. So joining us today is Betty Jo Rocchio. She's a Senior Vice President and Chief Nursing Officer of Mercy. Betty Jo has served as Mercy CNO since October 2020. And before that, she was the Chief Nursing Optimization Officer. Mercy has 30 hospitals. It has $5 billion in operating revenue. They are across multiple states, including Missouri, Arkansas, Kansas, and Oklahoma. They have over 40,000 coworkers and 900 facilities across their system. Mercy has also earned many accolades, including being named a top employer by Forbes magazine and is one of the top 5 large US health systems as identified by IBM Watson Health. Betty Jo, thank you so much for being with us today.
I am so happy to be here with you. So can't wait for the conversation.
Fantastic. All right. So just as a reminder to everyone, we are recording the conversation today. And we will be sending it out after this event is over too. And the chat is open. Please feel free to share your comments, ask questions in the chat. There will be plenty of time at the end for Q&A as well. But you don't have to wait till the end. You can, keep going with your submitting your questions. So our agenda today is we're going to be going over the state of the nurse labor market nationally, how CNOs like Betty Jo are thinking about making nurses' jobs easier, how to create a more positive work environment for nursing. We're going to cover the sometimes controversial topics of nurse compensation and scheduling, and then certainly going to be covering permanent nurse hiring and career advancement and how Incredible Health can help. All right. So let us start with just an overview of the nurse labor market. What's going on today? And I know that Betty Jo's in the middle of this, as well as many of the attendees on the call. So our demand for healthcare as a country continues to go up, right? Our population is aging. Of course, pandemics don't help. They are demand shocks on the health system. But the supply of workers does not meet the demand. And 1 in 8 Americans today works in healthcare. Healthcare has been the #1 employment sector in the US by number of workers since 2018. Now, the problem is happening across the entire country. And what we are all experiencing is we are on track to be 1 million nurses short by 2023. So we are dramatically undersupplied when it comes to nurses. The turnover is going up. Right now, the average turnover for hospital nurses is at 21%. We have some health systems that are a lot lower than this, some that are higher, but the national average right now is 21%. It has increased by 2% in the last year. So COVID has increased nurse turnover across the country. In addition, 48% of revenue is spent on labor. So the labor costs are increasing. So we're not just talking about the temporary labor costs, but even the labor costs of permanent workers and permanent nurses is increasing because their salaries are going up. The bonuses and other incentives are going up. So we are just seeing overall wage inflation happening, and it's projected to see that for the next 12 months as well. And the average time it takes to hire a permanent nurse today in a permanent specialized nurse today is 82 days. And which is long, given how long given how urgently we need more permanent nurse staff. All right. So one other piece of information that we wanted to share, this proprietary information from the Incredible Health platform. We have hundreds of thousands of nurses on our platform. Tens of thousands sign up every single month. And we always ask, what are the top reasons why you're changing your job? So why are you considering leaving your current opportunity, your current job? And these are the reasons listed here. And they're in order of prevalence that the nurses select. Number one, that by far the top reason that nurses change jobs is to advance their career, right? To expand their skills, to move up into management, to cross-train, something to do with advancing their career. The second most common reason is because I need a more flexible schedule or just more balance in my life. And the third is I need to reduce my commute time or I'm relocating. And then the fourth is better compensation. We often talk to hospital executives across the country. They think number 4 is the top reason. It's actually not. Number 1 is the top, advancing your career is the top reason. Yeah, I'm getting questions around how old this data is. We've been tracking this data for multiple years now. There hasn't been too many shifts in the last 12 months. And then so the CNOs and the CHROs that are adapting their strategies and tactics to what the nurses are looking for are doing better in the market than others. And we're going to be hearing what many of Betty Jo's tactics today. All right, so I'm going to stop sharing slides. So Betty Jo, we'd love to hear a little more about how Mercy's been impacted by the pandemic and even especially more recently with the Omicron surge.
Well, as I talk about this, everywhere that I talk about it, this has been coming on for a long time, right? The pandemic really just sped up where we are in the progression of needing more nurses, but we've been dealing with this for over 10 years. We knew, right, we were going to end up here, but we didn't know this pandemic was going to influence us so quickly. And so having like 30 acute care hospitals plus 10 specialty hospitals and 40,000 employees and pretty much close to 10,000 nurses, if you take a look across our whole system, it's hitting us fairly significantly. And we are right here in the middle of the Midwest, looking at our pipeline supply and things that are helping us attract nurses. But at the end of the day, the Omicron is not only impacting nurses working in our market, but our current nurses are coming down sick at a really rapid rate. And so thank goodness that people aren't getting really ill, but they're out for anywhere from 5 to 10 days, depending on how ill they are. And so we're starting to see that as well. So the real problem isn't just that we can't find nurses in our market, but it's really that those nurses that we have today are also sick. So it's adding up to really impacting us in our staffing.
Got it. And there's some shifts that you've been doing where non-clinical Mercy coworkers are helping out. Would you be able to share a little bit more about kind of your strategies and tactics there when you're addressing the Omicron surge?
Yeah, we know that nursing is going to be tasked with doing some of the more critical thinking about the care of the patient. But there are several tasks that nurses over the last 10 years have been doing that really non-clinical people with a very small amount of training could come in and help out. And so what we've done to help out now that some of our nurses are out sick is our non-clinical, as well as some of our clinical nurses that don't perform at the bedside every single day are joining us at the bedside to be able to help improve our care. Many people need a ton of things done while they're in the hospital, including, right, stripping our beds, helping us with even picking up some of our trash around the hospital, transporting patients, delivering meal trays, sitting with patients that need care companions. All these things can be done by non-clinical people. And so we're infusing current employees as well as people from the community into our hospitals to be able to help us out at this time. And we've had an overwhelming response. We have over 500 temporary workers in Mercy as well as outside of Mercy that are in our hospitals today, helping us provide that care. It's been pretty impactful.
Got it. So at the end of December, your governor ended the COVID-19 state of emergency order, the Missouri governor, Mike Parson. And for hospitals, that meant about 600 regulations that had been waived because of COVID are now back in effect. And that included things like, we weren't no longer able to shorten employee onboarding time. Hospitals couldn't just turn their rooms into ICUs. Curious about how this reversal of the emergency order has impacted your team.
Well, so we were pretty creative during the early days of the pandemic, and lifting this type of order makes us go back into more of that routine structure that we operated in. That, by the way, wasn't really serving us very well in the midst of a nursing shortage. And so now we're forced to go back into more of that regulatory environment that we kind of stepped to the side of. And so I think what you're going to see is it's going to take us longer to get nurses onboarded and through all the training that they need to. The other thing that's impacting us in Mercy is we have one virtual hospital where we have no patients. So the licensure requirements of physicians, nurse practitioners across the states, we're starting to look at maybe is that going to get reversed? So, that's going to impact us being in 4 states. So we're taking a look at it. We have a big government relations team that's helping us with some of this, but we're hoping that we don't completely go back to the way we were. So it is going to impact us though. It's going to slow us down a bit.
Okay, got it. So how's you and the rest of your peers in the C-suite preparing for or addressing sort of the nurse staffing crisis that we're all tackling?
Yeah, these are really good questions, right? So I think there's a now thing that we're addressing that we can get lost in where we are today, but starting to pivot to the near and the far. I think we're going to have to start thinking about nursing and delivery of care standards in a little different way. So today, right, we are competing for our shortage because it takes us a little while to get ourselves going. But when you look at the future state of nursing, we're really starting to address a couple of things. And you started to see it during the pandemic, which is our care delivery standards. We are heading towards more of a team-based approach. But there's going to be an infrastructure and a support that's going to be needed to be able to carry this on past the pandemic. And I think we're going to have to shift our thinking. So in Mercy, we're shifting all of our thinking around where we're headed for the future. So we're developing some major work streams really to help us with that, because we're starting to realize we have to meet the needs of really our coworkers and our nurses, and it's not the other way around. So we have to take the personal impact of everybody that works in our health system and what they're looking for, and be able to translate that into near far work on what the future of nursing is going to look like and the care delivery models. And so, I don't think we can stop with where we are today. I think you're going to hear today about a couple innovative strategies that I won't reveal quite yet, but we're starting to look at what we need to be able to make this back into a professional lifestyle for our nurses, so they're supported and it supports your data. What it's showing, number one, is they want career advancement. So you're going to hear a little bit about that today. And they want flexibility. And so, the 12-hour schedules may be a little bit of a thing of the past.
Yep.
I think we're going to have to open that up a little bit.
Yeah, got it. Okay, so let's dig into this topic a little bit more around sort of redefining the nurse job. I think you call it nursing in the future, which is kind of pretty much the present, because we all have to move pretty quickly here to address some of these challenges. So, the key piece, a key part of the nursing crisis right now is burnout, right? We saw that the turnover rates are going up. Like nurse retention is becoming more and more challenging. We also see from our data that the second most common reason nurses change jobs is because they want more flexibility and they want more control over their schedules. So curious about how you're thinking about workload and sort of how you're defining the nurse role.
I love the way you said workload, because I think that's the key. In nursing, we tend to talk about acuity of patients, which is also really important, but that's really important in an ICU setting. Workload, right, becomes important when you take a look at work environment and what the nurse is doing daily, right? What we have put on that plate of things for them to accomplish. And so I think it is going to come down to what does that workload really look like, and what are the creative solutions to help us get out of that. So I think one of the things we have to turn to very quickly is how can automation, technology, driven by a little bit of analytics, change the way that people work. So I think that's going to be very important to take a look at, not burdening the nurse with technology, but assisting workflows. So I think that's going to be one of those future things that needs some focus.
Got it. And, nursing is also there's 45 different specialties within nursing. So how are you, when you're thinking about workload, are you thinking about it differently depending on a specific unit or specialty, or love to hear a bit more about that?
Yeah, kind of both ways, right? We're taking a look at it from just a global perspective for nursing, what workload looks at for nursing, defining out what nursing owns,
Yep.
and where we can actually take some of those task-driven things off of nursing. But you're right, it is by specialty as well, because the ICU environment looks way different than a perioperative environment. So it's going to take just globally a look, and then we're going to have to dive down into the specialties. And I would suggest we include our physician partners as we, by specialty, as we're starting to do that. So I think it's going to be more of a interdisciplinary approach with the CNO at the center of the knowledge about what nursing can do and not do.
Got it. Okay. Would you be able to share some of the roadblocks nursing is dealing with when they want to stay engaged at the bedside and they want to care for patients?
Yeah, so everything is basic as our EMR today. The EMR, while it's been a great tool for information, it silos nursing into kind of their spot on where they chart and what they do. And if you take a look at how we chart today, it's basically on a workstation, right? So it takes you out of the bedside. So you'll see many nurses today have a ton of notes near the end of their shift, and they're going back in and feverishly charting. I think charting could be worked in to those workflows at the bedside. And depending on your EMR, we're starting to release a mobile clinical platform for our nurses, so they never have to chart away from the bedside. They're using something called a Zebra phone today, but it's that technology that allows us to voice chart, so we don't have to have so many keystrokes. We're scanning supplies and medications at the bedside with, basically our phone, like it looks like an iPhone today. So we're starting to understand that the workflows that we have in our personal life can be translated across into our professional life, to make the stress of that much easier and keep the nurse by the bedside.
Got it. The other phenomenon we're seeing is, nurses have to support more and more and more patients. And we're not just talking about COVID, but even all the other morbidities are increasing. And health systems continue to expand. They continue to add facilities, and it's definitely a growth area. But we're struggling to get enough staff to service all of those patients. Kind of how are you thinking about helping nurses manage more and more patients?
We're taking a look at that unlicensed personnel, and we're starting to understand we're going to have to start from that very basic entry-level position and continue to grow our unlicensed personnel. So for example, almost all of us use patient care techs in our environment that help us with our care. In Mercy, we had over 60 job descriptions for that role. And so we just finished a large undertaking with standardizing that tech role with competencies. So we're moving that tech role along as well. There are no board of regulations that prevent non-licensed staff from helping, even from properly trained, inserting Foley catheters, inserting IVs. They can do that if the competency is on file. So we're starting to group the competencies by patient care techs, patient care assistants, care companions. So everybody can keep moving along. Just as nurses want career advancement, so do our unlicensed personnel. So we're keeping that career ladder building for them. And then at the very top, at that nurse tech role, they're moving into sometimes becoming LPNs, RNs. So we're trying to keep our own internal pipeline moving and progressing people in their career advancement. And that's been a big help, everybody understanding what their role is on the unit.
Got it. Okay, you mentioned the EMR earlier. Is there other technology advancements that you're using to help nurses with their workload?
Yeah, we're using a ton of things today. One of the things that we're looking at is robotics. So we did a pilot in one of our hospitals where we had robots that were delivering supplies. They literally walk in the hall, with everybody else. They deliver supplies, they take things back and forth to the lab, bring things from pharmacy. And so adding in robotics and that automation to help with the manual labor side of things. So that has been quite successful, and we're starting to expand that to all of our hospitals.
Okay, so and I know that another tactic that your team is using is just reducing the number of patients that end up in the hospital, and that also helps with nurse workload. How are you thinking about that?
So one of the fortunate things in Mercy is we're highly automated, and we do have that virtual hospital. So we are starting a process where we triage where patients go for care. So we have a call line. So before you show up in an emergency department, we've got physician offices, we've got urgent cares, we have emergency departments, and we have a virtual component where we can schedule a virtual visit with you. So we're starting to launch a consumer-based focused care model where you actually call into the health system and talk to nurses and other people that can help you get to the right level of care and can set you up before you go there so you know where you're going. And so with that virtual care aspect, we're keeping a lot more people at home as long as they don't have acute conditions. So it's about keeping them out of the hospital and seeing them in the environment that meets their acuity, as well as sending people out to see them rather than bringing them to us.
Got it. So we have hundreds of attendees on this call. They are nursing leaders, they're HR leaders, they're also operational leaders. And what advice would you have for them when it comes to figuring out ways to make the nurse's job easier, and which, by the way, leads to more retention?
Yeah, it's not just nursing, and that's a really good point that you make. It is literally our HR professionals, our physicians get involved, frontline nurses are involved, right? So really designing work without the frontline involved is one of the more dangerous things that we can do, because their opinion matters to us. And so, we have a group of trusted nurses across the ministry that are giving input into all these strategies, as well as HR professionals. So we're working together to really design what the future is going to look like. Rather than trying to control the number of nurses coming in, we want to make it a culture where people want to be with us. And so we're really designing that pool into our health system.
Okay, so like building on that. Okay, so we've covered how you're thinking about changing the nurse role and how you're thinking about their workloads and frankly reducing the workloads. The other thing you just touched on is like making this a really positive work environment, right? Collaborative, positive. How are you thinking about culturally, or the organizational culture of many of these changes?
Yeah, so we are also, by our side, we have an organizational effectiveness team that deals with change management. So we have a change management strategy around the nursing workforce. And so we're not trying to do this on our own, but we have a very explicit plate of things that we're heading towards to be able to change the workforce. And we have change management that's in place to help us. So every nurse across the organization is involved in the communication. And we have several cascades of meetings where this happens, but that change management approach of the constant communication coming out for where we're moving and where people can get involved has been key.
Got it. One of a common reason nurses leave jobs is because of their manager, right? It's just a truism. I think it exists in every industry that people don't quit their jobs, they quit their managers. So how's your team thinking about just supporting nurse managers in particular, and making sure they're creating a positive environment for nurses?
Yeah, so one of the things that we want to support is our culture, and it is that frontline manager that's the most important piece, along with the frontline in building that culture. So it's that nurse manager level and supervisor that's really taking the brunt of all the changes that we have to put in place, because they have to operationalize them. And so getting down to the details with them on what this might look like has been very important, and bringing them key into the design-centered concept of where we're moving has to happen, because they have to work in it every day. And so they know their challenges. So it's not enough just to meet the frontline challenges, but having the nurse managers involved with us to design what that might look like has been key. And especially when, as you talked about, there's about 45 nurse specialties. The managers look different in each specialty. So working on where that might be. And some areas have a large amount of change and other areas have small tweaks to get them where we need it to be. So, we're working alongside of them. And by the way, what I will say is understanding that manager role is the most difficult role and making sure that they have support at the unit level.
Okay.
So we're starting to look at that.
Got it. So, research from the Journal of Nursing Administration shows that nurse managers can practice to create a more positive work environment. Examples are debriefing after a patient death, making sure staff are getting their breaks, their meal breaks, meaningfully recognizing nurses and showing that they're valuable and appreciated. For some of these, sort of tactics, how are you implementing those? Is it through manager training? How exactly do you make sure your nurse managers are creating this environment?
Yeah, we're creating a standard learning platform for leaders, right,
Okay.
in Mercy, because it's important that they learn what it is to be a Mercy leader, because the way they are in their space determines, right, the outcome of not only patients, but, our nurses in general. And so we're starting to take a look at standardized training for them, a resilience training. Which I think is going to be very, very important. We're looking at how burnout the front line is. I would say the managers are equally as impacted. So, how do we support them along with the entire nursing workforce? We're watching managers leave those jobs just as fast as nurses are leaving us across the country. So,
Got it. All right, so let's transition to the topic of nurse compensation, and then we'll cover nurse scheduling. So on. Look, everyone's struggling with compensation. There's very big wage inflation happening across the country, and it's projected to continue for many, many months to come. And frankly, it was already happening even before the pandemic. And would love to hear kind of how you strategically think about nurse compensation, and especially how you balance the compensation for your new hire, for the hires that are coming in, the nurses that are coming in, as well as the nurses that are already there.
yeah, that's an interesting concept, right? We've been heading towards, during this pandemic, we started out with a real recruitment focus, right? We need more nurses. We have to recruit more nurses. Well, nurses aren't really in the business of being recruited today. They're in the business of leaving where they are.
Yes.
So it's really an interesting paradigm. It's like a funnel, right? Recruiting's pouring into that funnel, retention's flowing back out the other side. And so it's that dual role of where do we head? It's very expensive to onboard a nurse. So when you take a look at that movement that occurs when people leave you, it's very expensive to onboard. So the real key should be recruitment, but we still need more people coming into the health system to support us. So it's that balance. What we did was, right, we offered a ton of bonuses to get people in, and we forgot about our experienced nurses who've been by our side providing care. And when you take a look at the pay bands in nursing and where the experience lies, it's not people coming in. They don't know your culture. Some of them are brand new to nursing, a ton of new grads coming out, thank goodness. But we need the experienced nurses to enculturate them into what it is to be a nurse these days. And so we're starting to invest in bringing more nurses in, obviously, through bonuses, but we're starting something called a total reward strategy for nursing, which focuses on more than just compensation. You showed us the compensation was really the number 4 thing. Now it's important. They're going to want it, right? But flexibility around that's very important. So we're starting to take a look at programs that focus on the total well-being of everybody coming in. And so we're starting to look at what's important to their personal lives. And we're starting to see that daycare is starting to become an issue. So we're compensating a portion of their daycare expenses now. So they can come to work, they can focus on work and know that their children are taken care of. So we're focusing on that. We've also learned what's important is volunteering in our communities. And so we're giving them paid hours to go out and volunteer in their community that are paid by Mercy. So it really helps the whole community. So we're starting to take a look at that. The other thing is we're starting to pay for longevity. And so we have something called a loyalty plan, where once you've been here 2 years, clear up to, 40 years, it's an escalating pay that's completely different from their base that allows them to stay in Mercy and be rewarded. We know that once you've been in a health system for a long period of time, you have just a lot to offer for enculturating everybody else into the health system. So we're starting to pay that loyalty pay band for people staying in Mercy.
Got it. So you're looking at a total reward strategy, loyalty pay. I love that, the phrasing. You're also just increasing your base rates, right? Like, and looking at that more frequent. Like, instead of looking at it every 12 months, you're looking at it every 6 months, just given how quickly the compensation numbers are changing.
Yes. And we're also starting, the other concept that's here is, we used to look at compensation by region or location, but we're now competing with external agency. And so we're starting to take a more global approach to compensation to try to retain some of that. So that's the other thing that's going into the strategy section.
Got it. Yeah, other strategies that we've heard from other leaders across the country includes creating your own internal travel agency. So, employing your own travelers, and essentially they're still your employees, but with higher pay. But in exchange for higher pay, they have to provide a lot of flexibility. They have to be open to every location in your health system. Float pools are getting bigger and bigger as well. And that was a strategy before the pandemic, but that's increasingly almost every health system now at this point is using the float pool strategy. And so those are some of the others that we've come across around just flexibility with compensation. You also mentioned the performance, using performance measures to drive compensation. Will you be able to share a little bit more about that and how as it relates to nursing?
Yes, every health system has top level goals that they put out every year as part of their operational plan. We are taking a look at not only compensating leaders for the performance that we put out there, but we're starting to take a look at frontline staff sharing in that compensation package to drive the right goals. For example, when you take a look at CLABSI rates, we know that the frontline nurse is directly impactful on dressing changes to having that measure roll up and prevent untoward outcomes for the patient. So we're starting to take a look at what it's like to put 1 or 2 performance goals in our annual yearly review of frontline and compensate them for the performance on their units. I think that's going to be highly impactful moving forward to the health system.
Got it. All right. So let's move on to the topic of flexibility in their schedules. How are you thinking about that topic strategically at Mercy, and because we know it's the second most common reason why nurses are changing jobs and leaving the health system?
A couple of things. So I think for clarity, I'd like to break down the workforce layers that we're thinking about, because the strategy moves a little bit, and then we'll talk about the common themes. Your core coworkers are your base, your full-time, your part-time. What we're building in there that's new and different is called a part-time flex position that doesn't schedule by shift. It schedules in hours. And so our software system, our scheduling system, we're starting to move away from shift scheduling and move into hour-based scheduling. Now, I'm not saying, we're not telling a nurse she can't work from 7A to 7P, but it's going to be scheduled in hours, not in that shift. And so we're starting to take a look at where people want to work. Mothers that may be able to get their children on and off the bus. We're starting to take a look at where the productivity needs are and then lining up the hours in our software and scheduling system rather than being locked into shifts. If you look at the research, 12-hour shifts are a large contributor to burnout the way it stands today. So we're starting to move away from just that flexible staffing and scheduling in that core group. The other thing you may be thinking is, well, Betty Jo, that sounds great, but how are you going to cover the needs of your unit? It's about opening up something called a gig workforce that allows them to come in and pick up the extra hours that we need for a certain rate, right? So we're talking about matching hours of work to flexibility and then the compensation for the flexibility that we're given. We know that night shift is not popular. So we're taking a look at not just the standard, how much more money do you get to work, but when you work at night, how can we drive the incentive to where we need people to work? If you look at it, it's not unlike the Uber concept. Obviously Uber's, done with, rides, which isn't as important as people's lives. But the concept and the math behind it, used correctly, can drive exactly where you want to go, and have people pick up shifts that meet their flexibility and the compensation that they want for that flexibility. So it really opens up the workforce outside of the health system, and opens it up to people maybe working at the hospital across the street, but you get their extra time, maybe their overtime, or if they just want the hours that you have available. So I think those that have the most flexibility with variable compensation are going to win in the end of this. So start thinking about that a little bit.
Yeah, absolutely. So yeah, the 12-hour shift 3 days a week, maybe a thing of the past.
Yep.
And even if that does stay, we're seeing that hospitals and health systems that add more part-time roles and more flexible options hire more as well, and retain more. And that's definitely showing up across the country as a key strategy. Now, it's more operationally complex, of course, internally, but we need to be as nurse-centric and talent-centric as we can in order to retain and hire nurses. Another, along the same lines, some health systems are giving more, frankly, power to the HR team, right? Where the talent acquisition team is able to create roles on the fly. They can be on the phone with a nurse, and the nurse is insisting on a certain schedule, and the recruiter can create that role for them. And then the other thing that, I just want to call it out because it's a very controversial topic that many CNOs have to tackle. The whole thing around more tenured nurses get the best hours and get the best shifts is also a strategic shift that needs to change. Because when you're trying to hire nurses, and all the day shift positions are gone, or they're taken by the more tenured nurses, then you won't be able to hire, right? Because the new nurses, the nurses you're hiring do not want the night shift roles. So everybody, whether it's your current nurses or the nurses coming in, need more flexibility. I'm curious, just got kind of on your thoughts on that the controversial topic on how to treat the tenured nurses as it relates to scheduling.
So that's interesting. So my thinking on this topic and where it came from is I watched what happened during the pandemic for travel nurses, right? When they all started going external, I really watched that behavior. I'm a big watcher of behavior and then trying to match that to your needs and bring it in rather than trying to fight the system. And what they looked for was flexibility. Most of them wanted days. So when we started, really ramping up our external hiring of agency, it isn't about experience. So this is going to be, it's about what the nurse wants, right? Because there aren't going to be as many experienced nurses, right? And so when you look at how the external travel group was paid, there's no difference. As long as you had a year experience, you were making the same as somebody out there standing beside you, right? Doing the same work. Now, I'm not saying I'm ready to collapse pay bands completely, but I am looking at that seemed to drive a lot of behavior and how we can take a look at what occurred there and go back in. And that's that math in the background of driving people towards the shifts. Some people, right? I don't think we're paying enough differential for having people move to the shifts where we need them. So I think you're going to see a wider swing with that, but you're going to need some technology to do it. It's not going to be able to be done manually. So you're going to have to start thinking about, how do you take a look at data in the background to know when you've hit the sweet point of having people move to picking up that shift?
Got it. Okay. So let's dive deeper into the topic of nurse recruitment. And then we'll talk about career advancement as well. So, you have some very innovative recruiting programs, including sounds like the hiring of unlicensed personnel to help out. Love it if you could share a little bit more about how you're thinking about nurse recruiting, including the hiring of experienced nurses and your new graduates.
So I believe my philosophy is the hiring phase starts while they're in school. As soon as somebody gets accepted to a nursing program, I believe the CNOs needs to be on their radar. They need to know what that pipeline is going to look like and manage it coming in. And so one of the really creative things that we've done is partner across the entire health system with our schools of nursing and our deans of our colleges and create something called Earn as You Learn. And so the state boards of nursing, one of the things it did during the pandemic was release requirements that nurses could be paid during their clinical time. So really quickly iterated upon that and put in an Earn as You Learn program. And so if people early in their careers, like within their first year, after they take their fundamentals class, sign on with our health system, we will put them in the Earn as You Learn program, get them into our health system and pay them for helping us while they're doing clinicals. That's pretty innovative and it catches that pipeline a lot earlier.
Okay. And then anything that you want to highlight anything that's different about Mercy's nurse recruiting process compared to, other traditional health systems?
Yeah, so we're starting a 3 kind of tiered or lane approach to coming out of the pandemic. I said to always go now and then go to the near and the far. And one of the near things we're doing is making a conscious effort at redefining skill mix. And so you're going to start seeing, we're going to flip the paradigm on the number of nurses that we need versus our PCAs or our non-clinical, as well as adding nurse practitioners into the units to help manage care. And so you're going to start to see a tiered system of who's managing the care, who's delivering the care, and who's assisting in the care. And I believe that's going to give us the greatest strategy to be able to take care of patients in the hospital. And you're going to have that higher look of the nurse practitioner helping to manage care planning and managing length of stay. So it's about capacity management and the staffing demands coming together to make sure that the patients are getting the good quality care. So I think you're going to start adding in some innovative skill mix models into it. That's going to become very, very important as we move along in this pandemic. The other thing that you asked me about that I think is important is recruiting is changing. And so recruiting needs to become a personalized approach to each candidate. You hinted on it when you said, we're going to start iterating at that front line to be able to give people what they need. What we're doing is we have a front door for a recruiting process that we've had in place for years. And we're developing something called the Professional Practice Development Center that takes that coworker, that potential coworker from that front door recruiting and moves it across to some professional recruiters that understand what we have in each of our hospitals today, and puts them into a career development plan as soon as they hire on. So it's that thought of, I hired into this health system, they have a plan for me, and I have a place, a center where they're going to keep my career moving along. So it's not up to each individual manager to try to come up with these plans. And I think that's important because the manager is busy. And so we're starting to recruit and hire in a whole different way. The other thing is we're starting to look at a talent assessment for frontline nurses that helps those new grads not only take into account where they want to be professionally, but where their talents lie and where they would be the best fit. And so we're starting to take a look at that as well as culturally, what unit would they fit in best on? So it's really a 3-tiered approach to getting people to the right place, exactly how they want to work, and then how do we keep developing them in Mercy? And so it's pretty complicated. It takes a lot of thinking, but it's that individual approach to the hiring and the development of nurses in your system.
Absolutely. I mean, that tackles the top reason that nurses are changing jobs, and that's for career advancement. So you have this professional practice development center, and what are some of the other tactics you're doing to help nurses advance their career even after they join your health system?
So we a new grad may come in and decide that they want to be an ICU nurse. We may foundationally put them on the ICU career path, sign them into a career path. There's a contract. But for the first 6 months, they're on med surge, kind of working along, learning the basics so they don't get overwhelmed, with a plan to pick up so many shifts on the ICU. And then they transition into the ICU. So that career development plan has been important, and developing competencies out of this professional practice development center to keep them moving on. So gone are the days where we're not going to promote nurses and help them get, if they want to be a nurse practitioner, they want to be a nurse anesthetist, we're forming those pathways to keep people in your health system. Because if not, they're just going to leave you and do it anyway. And so trying to keep them moving in their career path and help them any way we can.
Got it. And this is like, formalized, documented, like
Yes.
things are getting signed. Like it's not just talk that, hey, there's a career plan. Like it's a very real thing.
And we have all of our educators in our hospitals that are centered in this professional practice development center. So they're not out on the units. And so that's the workforce that's really helping us move and educate and make sure that they stay on plan and they have the competencies. They're all centered out of this center. So they're moving along, and we know that it's happening in every one of our hospitals.
Got it. Yeah. Several of the leaders we interact with across the country are putting in place career mobility plans. Even as, and it's even as regimented as, hey, day 120 after the start date, has the career mobility plan been documented and discussed between the nurse and the manager, just to make sure it's actually happening. And those are programs that are being set up collaboratively between HR and nursing too.
Yes, absolutely.
Great. So what we'll do next is we'll do a quick overview of what it is that Incredible Health does and supports hospitals and health systems. And then we're going to open up for Q&A. And there's a lot of questions that have already been submitted. So we'll try to get through as many questions as we can as well. So Incredible Health is a marketplace technology, and hospitals and health systems, they use our custom matching technology to hire high quality permanent nurses in less than 20 days. There's a few unique things about Incredible Health. First, the employers apply to the talent instead of the other way around. So this is a very nurse-centric platform, and the nurses absolutely love it because they create a profile, they sit back and relax, and they get to choose which interviews to accept or decline. We also have proprietary screening. So all nurses are going through our proprietary screening process. So we're only, and then we also build custom matching algorithms for every employer that we work with. What that means is that it's making recruiting much more personalized, right? So if, let's say there is a recruiter at Mercy using the system and they log in, it's not that helpful for that OR recruiter to be seeing, 200 nurses. That recruiter needs to be seeing, 15 that are the exact right fit for Mercy at the time, based on Mercy's requirements and the nurse's preferences as well. We also provide a whole robust set of data analytics that nursing leaders and HR leaders use consistently to identify bottlenecks. It includes benchmarks with other health systems and in their local area and nationally as well. The other thing is, the top nurses join our platform in the thousands, and we have a very rapidly growing nurse database. And one of the top reasons they join is because we provide a whole range of free services and tools for nurses that help them manage their careers. For example, we offer free continuing education to every single nurse in the country, so they can activate their licenses, and it's accredited in all 50 states. We have free salary estimators. We have an exclusive social network for nurses built into our apps where they can give each other advice, and lots of content that helps them manage their career as well. So it's always free for nurses to use the Incredible Health platform, and they don't have to use the hiring product, but they can use any of these other tools as well. Just some data just to share. Like, I know there were a lot of questions about the data that we shared earlier. Just so everybody's aware, based on our platform, we can see that 68% of nurses accept the very first offer they receive. And 61% of nurses accept the first offer, even if the second or third offer has higher compensation. So seamless internal hiring operations and getting nurses through your hiring processes quickly is a competitive advantage. We see that over and over again. Hospitals that have not necessarily the biggest brand in the market, they don't even have the highest compensation in that market. They're able to hire more because they have better and more streamlined and faster hiring operations. The other thing that just wanted to share another piece of data with everyone on the call, and this is from a team in LA, and and we have the different steps of the hiring process. And so for this team, we were able to get the days to fill down from 66 days down to 19 days. And where we had the biggest impact was on time to source. Sometimes just finding the nurse it really elongates the days to fill. And we do shave off days later in the process too, with automated interview scheduling, other features that we provide to the employers as well. But really we're trying to reduce that days so the health system does not have to spend as much on travel nurses and doesn't have to burn out their nurses and doesn't have to spend as much on overtime as well, and get these permanent nurses hired faster. We also track retention. Every nursing leader cares deeply about retention. It's a very important metric. Our data shows that when nurses are hired through the Incredible Health platform at the year 1 mark, the retention is 15% higher than the baseline. The reason for that is a nurse was able to consider multiple opportunities before selecting a specific health system, for example, before specifically selecting Mercy. And it was a very well thought out, thorough job search process that they went through. And so they know they've selected the right fit for them. This is sort of a newer model in hiring as well. And I know, Betty Jo, you spoke to some of this around ensuring that nurses can operate at the top of their license and the specialization of their skills, bringing in more unlicensed professionals. The same transformation is happening in HR. We need recruiters to be operating at the top of their skill set and expertise too. And this is just a slide from the Stanford team. This is a true collaboration. It's a true partnership, right? So with Incredible Health, we might be helping and supporting and doing the heavy lifting in the first 4 steps of the hiring process: the sourcing, the screening, the confirming, making sure the nurse is actively looking, even getting that first recruiter phone screen automatically scheduled. That frees up the talent acquisition team and the recruiter's time to do what they do best, which is talking to candidates, right? And building those personal relationships with candidates. And so with this model, the recruiters are able to spend, complete those phone screens, get the hiring manager interviews scheduled and getting offers out. And because there's automation and technology that's helping them with some of this much more administrative work that's happening in the beginning, like sourcing and screening and scheduling. So this is really a newer model that talent acquisition teams are moving towards, because even the headcounts in HR are not increasing rapidly either. And we really need to find ways to do things more efficiently and better. We work with over 500 hospitals and health systems across the country, including very big ones like Kaiser Permanente and Baylor Scott and White and HCA. We work with many academic medical centers too, like Stanford and Johns Hopkins, and lots of community hospitals as well. All right, let's dive into Q&A. We've got 8 minutes left, so we should be able to cover quite a few topics. For those of you that are interested in learning more about Incredible Health, our team will reach out, but you can also sign up on our website, and then Allie and our team will share some Calendly links if you wanted to book a time. She'll share it in the chat now as well. All right. Let's start with Michelle Carter's question. So when you review, I think this question's for you, Betty Jo. When you review the global workflow for nurses, and what can be done in different levels of care. So for example, workflows in acute care are very different from long-term care. And so how can a director of nursing and long-term care, in other settings, think about the workflows of nurses?
So I think it's about meeting with your frontline and mapping out what they're doing today, and then looking for ways to make it faster and easier. I always say, look where the friction is, and then try to eliminate that friction, right? Through either technology, reassignment of things. We've been doing things in nursing the same way for a lot of years, and it's leading to frustration. I mean, we have nurses that somebody wrote in the chat I saw, and spot on, that nurse practitioners are going to nurse practitioner school so they can get away from the bedside. They don't necessarily, right, want to be a nurse practitioner. Well, we're not doing something right. When people want to get away from the bedside, we are, and it's more than just being short. It's about addressing that workflow and the expectations, right, of what we're expecting. So, I think it's the same for everybody, but it needs maybe a different lens for who's looking at it. But the frontline have got to be involved with you as you look at it.
Got it. So this is the next question is from Jose, and you mentioned using technology, right, to help nurses at the bedside, help with their workloads. But you mentioned, technology used in nursing also can increase costs. So how do you balance the benefit to the nurses versus the increased cost of the technology to the organization?
Yeah. So through 2 main ways. So if the technology is enhancing communication and reducing medical and nursing errors, that's a no-brainer, right? So we're starting to track when we add technology in, we're starting to look at what it's doing to our quality metrics and our retention metrics, right? Is it satisfying to the front line? Are we improving anything? And so those are the two main metrics. And, at about $45,000 to $50,000 a nurse for onboarding and turnover, it would definitely pay off if you kept track of your metrics.
Got it. Okay. And then a question from Susan: the strategic achievement goals around performance. Are you looking at that as well for your merit raises for nursing?
Yes, absolutely, 100%. They will be completely tied into through their yearly evaluation. They'll know exactly what they have to hit, and when they do, then their pay for performance will go up. Yep.
Got it. I think you'd mentioned talent assessments earlier. So I think Pat was curious about, what talent assessments are you using and how you're thinking about that.
Yes, well, we use a company out of Nebraska, and it's a talent assessment. And what we did as a health system is we went through and looked at the talents that come up, and we mapped it to what a perioperative nurse's top talents might be, and ICU nurses, a women and children's nurse. They have different top talents likely, and we map those talents to specific nursing specialties. And then when we get the talent assessment across, if somebody comes in and says they want to be an ICU nurse, but their talent leads us to think they might be better in the women and children's area, we can have a conversation about that in the PPDC. We're not going to override where they want to be, but we keep the talent assessment on file. So if they're struggling, say in the perioperative environment, we will likely try putting them in the women and children's next, because that's where the talent was. So we use it as another data point to help people figure out where they want to work and where they want to be.
Got it. Another question came in about the new grad, or earn to learn program. This is a question from Michelle Carter. Is there a commitment to the organization after the new grad goes through that earn to learn program?
Yes, they've already signed on to become one of our nurses, and we have put them into a special category that we're taking extra time with them. We're making sure they understand our instance of Epic. We're making sure they understand our IV pumps. We're taking that extra time, and we're paying them for them giving us back that time to learn our health system. So we actually are starting our orientation early, if you think about it. It gives that new grad money they need for school. It gets them onboarded in a much more elongated way, so they're not so stressed out when they get out of nursing school. And that last semester or two of nursing school, we try to put them on the unit where they think they might want to work. So we're really making that push to making sure our new nurses are getting enough time to get enculturated, not only into nursing, but into the unit where they're going to be. It's a win-win on both sides.
Got it. There is many, many more questions. I know we're almost at time. We will try to get as many questions answered as we can after this webinar as well. And you can also send your questions to questions@incrediblehealth.com, and we'll work with Betty Jo to get them answered as well. And Ali has already shared our link around requesting a demo or meeting with our team as well. And just wanted to thank you so much, Betty Jo, for sharing your knowledge today. I think just by the volume of questions that came in, I think you've spurred a lot of discussion and thinking in the audience as well. And how can anyone get in touch with you, Betty Jo? What's the easiest way? Through LinkedIn, or what are your preferences?
I'm on LinkedIn. You can do that, or my email. I'll even give it out if there's any specific questions. It's betty.rocchio@mercy.net. And we can connect through you as well. So sounds like we're like thinkers.
Absolutely. Yeah, there's the future of nursing it's exciting, and it definitely requires transformation and innovation and change, because what we've done in the past is not necessarily going to work for the future. So we do need new strategies, new tactics. And so thank you so much for sharing with us today, Betty Jo.
And appreciate all the work in Incredible Health, because it's going to take partners. We have different levels of what we can take on in our hospital. So appreciate you as well.
Absolutely. All right. Thanks, everyone. Thanks, everyone, for joining.